Hello, and welcome to the CAP Today webinar for Wednesday, March 5th. I'm Bob McGonigal, the publisher of CAP Today, and I'll be your host, and I'll moderate a question and answer session after our formal presentation. Today's webinar is entitled Testing for NRG1 Fusion, the new kid on the block of actionable pathogenic gene fusions. This very timely and very important session is made possible by a special educational grant from Diaceutics. I'll be sharing a little more about Diaceutics shortly. And today we have a single speaker with whom we've worked frequently, and it's always a pleasure to have Dr. Pranil Chandra with us. He'll be the single speaker today. He's the Senior Vice President and Chief Genomics Officer at Path Group. Very well known, and like I said, he's hugely qualified to give this talk today for us. So it's a great pleasure. But before we begin, let me just go over a few housekeeping items. We want to make sure that you refresh your browser. And if you have any need for live help, either with listening or seeing the slides, just type in your Q&A pod that you see there on your screen on the Zoom, and we'll immediately help you with live help to get your technical problems solved. Of course, you're going to use that very same Q&A pod to make your comments and ask your questions. You can do that throughout any point in today's webinar. And we'll, at the end of Dr. Chandra's presentation, we'll catch our breath and then we'll launch immediately into your comments and questions. We'll be posting this full presentation on captodayonline.com in about a week. You can expect to see some follow-up emails from us and also from not only Path Group, but more importantly, Diaceutics, of course. And finally, it's important that you know that the CAP Today does not endorse any products or services that may be mentioned today. Any comments of mine are just purely personal, not to be taken as policy of CAP Today or the College of American Pathologists. And with that, we're going to go ahead and begin. I have, again, a welcome, and we're now going to show you a brief introduction to Diaceutics. It's filmed, and we'll go to that slide and start that. There we are.
On this laptop, hosted by Diaceutics. Diaceutics provides end-to-end solutions for the launch of precision medicine diagnostics. Using our platform, DXRX, the diagnostic network, we place labs at the forefront of developments in the precision medicine landscape. Our mission is better testing, better treatment. We believe that labs need to be involved earlier in the precision medicine decision-making process. We promote partnership and education to drive precision medicine, and the work of laboratories remains central to this mission. DXRX membership is free of charge and provides access to our aggregated data sets, the latest reports, publications, and laptop recordings, and ensures you're the first to hear about scientific studies and DXRX collaborations, such as EQA programs, grants, and global ring studies. Since 2020, we have executed over 30 collaborations covering a range of purposes, some of which have resulted in publications or posters at major conferences. Visit dxrx.io to learn more and register for upcoming laptops and collaborations.
Thank you very much. It's a nice introduction to Diaceutics. When you see them at trade shows or elsewhere, please do make yourself acquainted with them. They're got great resources. And now let me make my more formal introduction to Dr. Pranil K. Chandra. He went to medical school at the New York College of Osteopathic Medicine and did his residency at NYU Langone Medical Center. He's board certified in anatomic pathology, clinical pathology, hematopathology, and molecular genetic pathology. He did fellowship training at MD Anderson and also at NYU Langone. And since 2011, he's been at the Path Group with successive promotions. And as you know, his current title is Senior VP and Chief Genomics Officer there. I'm just going to go ahead and share his personal conflicts of interest with you, his disclaimers. And you can see, of course, he owns stock in Path Group and has relationships as a speaker, consultant, or advisory board member for a lineup of very, very distinguished companies in our space of cancer, including in particular relevant today to Maris. And so we want to share all that with you. And now I'm going to ask Dr. Chandra to begin his presentation. Dr. Chandra, it's a pleasure to have you with us. Please go ahead and start.
Thank you so much, Bob. And thank you so much also to the CAP Today team, as well as the Diaceutics team as well, for helping to put together this educational seminar. Without further ado, let's jump into our agenda and start tackling some of the topics that we want to cover today. And first and foremost, I wanted to talk to you about is precision oncology and what precision oncology is. This is a term, obviously, that's very familiar to all of you. And the term precision oncology, also known as precision medicine or personalized medicine, these are all terms that can be used interchangeably. Well, this practice of precision oncology, as I think you will all agree, has become more and more embedded into day-to-day clinical molecular pathology service for over a decade now. And traditionally, precision medicine allows for the identification of the right patient at the right time for the right therapy by performing the right biomarker test or right biomarker testing at the right time. Over the next few years, we're going to see this concept evolve, and we will see that cancers will continue to be defined by the molecular underpinnings of disease, thereby allowing for diagnostic molecular classification and prognostic risk stratification at the point of diagnosis. And this will be driven by AI algorithms incorporated into digital pathology, but that's a discussion for another day. Until then, the cancer care teams will continue to ensure that the right patient receives the right testing to delineate the right therapy at the right time. So for the time being, based on tumor profiling and biomarker testing, precision medicine allows patients to benefit from treatments that are more likely to bring positive outcomes in their care. These patients are appropriately stratified according to whether their tumor will respond to a certain type of therapy. So for example, if you have patients taking the precision medicine approach, let's just say that we have a patient with advanced lung cancer. The presence of an EGFR mutation in that patient with lung cancer will make the patient eligible for one of several types of EGFR inhibitors. So for example, if the EGFR mutation was an EGFR exon 19 deletion or an L858R mutation, the detection of that biomarker will make the patient eligible for the appropriate targeted therapies. What if the patient has an EGFR T790M mutation? Well, that patient is going to be resistant to most of the common and traditional EGFR tyrosine kinase inhibitor therapies. And what if you detected that mutation, the EGFR T790M mutation, in a treatment-naive patient? Well, now you've got potential diagnostic information, and the patient would need to be appropriately counseled by a genetic counselor and possibly undergo germline testing. Now, what if you have an EGFR exon 20 insertion? Well, Those patients have a very aggressive clinical course, and they do not respond to any of the therapies that I've just mentioned, including all of the EGFR tyrosine kinase inhibitor therapies. And there is actually another type of EGFR therapy that's FDA approved for those patients. So again, you can see that there's therapeutic information rendered from all of this testing. There's also diagnostic information. But as you will see, prognosis is becoming extremely relevant as we test patients earlier in their cancer care continuum. And that's going to be one of the underlying themes of today's talk. So this is one of several studies that I'm going to be talking about in our discussion today. And you can see the headline here, which indicates that availability of molecular genotyping results before first-line therapy is associated with significantly better outcome in a cohort of patients with advanced non-small cell lung cancer, non-squamous non-small cell lung cancer. And this is one of many publications that illustrate the benefit of genotype-driven therapy decisions and highlight the need to get molecular profiling results out ASAP. This was a retrospective study between January 2019 and December of 2020, and a fair number of patients that were part of this study. And so the genotyping results that are extremely important today for the management of these patients with advanced non-small cell lung cancer include BRAF mutations like the BRAF V600E mutation, MET exon 14 skipping lesions, ALK fusions, ROS1 fusions, RET fusions, and then KRAS. KRAS was undruggable for about 40 years. And recently now, there have been 2 FDA-approved KRAS mutation-specific inhibitors that are available as second-line options for patients who have failed standard therapy. So again, this is just a smattering of some of the publications, and this is actually one publication out of many publications that highlight the importance of therapy-driven therapy-driven decisions based on molecular abnormalities. Okay, so we have very strong evidence that molecularly defined lung cancers benefit from targeted therapy. So you would expect that personalized medicine to be firmly embedded into clinical practice of thoracic molecular oncology diagnostics as well as treatment management of patients, right? Well, unfortunately, that is not the case. And so the study that I'm about to talk about is a major study that was driven by the Diaceutics team, and they identified practice gaps where patients are lost in the context of advanced lung cancer, and thereby these patients are missing the opportunity to benefit from targeted therapies. You can see here that in their study, a whopping 64.4% of patients actually did not receive a personalized treatment. And among those patients who were eligible for targeted therapy, 50% were lost due to factors associated with biomarker testing. And also among those who did receive results from biomarker testing, almost 30% of eligible patients were not even prescribed the appropriate therapy. So let's unpack the results from the Diaceutics paper. This eye-opening study illustrated, again, all of the different practice gaps, which you can see here from practice gap 1 to practice gap 7 on the slide over here. And it highlights the challenges that exist in our healthcare system today that is preventing patient access to biomarker testing, good biomarker testing, as well as access to targeted therapies. These gaps span the pre-analytic, analytic, and post-analytic laboratory processes. So first of all, you can see that around 18% of patients are lost because appropriate testing was not ordered, or maybe the incorrect test was ordered by the pathologist or the treating oncologist or any other member of the cancer care team. That's a pretty significant number. And an additional 18% of patients are lost because biomarker testing was inconclusive, or there were false negative results, or there were technical limitations of the assay. So what do I mean by that? Well, in patients with lung cancer, you can have a high rate of quantity not sufficient because of the small nature of the sample, and maybe the sample was already tested with IHC to establish a diagnosis of non-small cell lung cancer. And so these are tiny samples to begin with, and so that poses a challenge to for actual completion of the test results. You could also have false negatives, and this can become a problem when you have samples that are on the border of moving forward with next generation sequencing. In our practice, typically, if there's at least 20% of tumor, then the molecular pathologist usually lets that case proceed forward with next generation sequencing. So sometimes the tumor percentage can be on the border, and in those instances, it's really important to have good reporting and maybe even go back. We've actually had borderline cases that wound up being negative. In a recent case in our practice, we went back, our molecular pathologist went back, recircled the tissue where microdissection needed to happen, and we were actually able to find a MET exon 14 skipping mutation. So in samples that have borderline tumor purity and they are negative, it needs to be mentioned in the report, and there needs to be a recommendation to either retest on tissue and or to perform ctDNA analysis. These are just a couple of the gaps that I've covered here, and there are many more gaps that are illustrated in the paper over here. And I would encourage all of you to read this really outstanding paper that was put forth by the Diaceutics team. Okay, so here I would like to introduce the topic of fusions and the importance of detecting gene fusions as key oncogenic drivers and therapeutic targets that facilitate the delivery of precision medicine. And you can see here that this is a study, and what they show in the 79 patients is that when you target a gene fusion with a gene fusion directed targeted therapy, those patients actually had improved outcomes. So again, this is just one of several publications that illustrate how fusion-directed targeted therapies improve patient outcomes. And I wanted to spend a quick minute to talk about that before we start talking about NRG1 and NRG1 fusions. So now we've established that targeting fusions is important for patient care. Let's shift gears a bit and talk about NRG1. Here we illustrate the role of NRG1 as key in normal signaling and development. NRG1 are proteins, and they're widely expressed signaling molecules, and they are involved in cell proliferation, cell growth, survival, and apoptosis. And this protein, NRG1, it's an extracellular ligand that binds to HER receptors, and that leads to activation of downstream signaling pathways that cause cell growth. And normally NRG1 is inactive until it's cleaved by proteases, and then it binds to HER3 and promotes receptor dimerization as well as downstream signaling. This is part of normal cellular development. So NRG1 fusions induce increased cell signaling and can lead to uncontrolled growth and tumor development. And that's illustrated here on the slide. So when you actually have an NRG1 fusion, the NRG1 signaling domain, also known as the EGF domain, remains localized to HER3 and tethered in the cell membrane by its fusion partner, resulting in HER2, HER3 signaling, which results in uncontrolled cell growth and cancer neoplasia. The fusion remains anchored in the cell membrane and binds to activate HER3, leading to, again, the dimerization of HER2 and the downstream oncologic signaling. As we will show in later slides, NRG1 fusion-positive tumors have certain histologic features associated with growth, recurrence, invasiveness, basically an aggressive clinical course and worse prognosis. And we'll also show in the ensuing slides how NRG1 translocated tumors respond poorly to available therapies and are associated with lower overall survival, disease-free survival, and progression-free survival. This is the largest molecular study of invasive mucinous adenocarcinomas to date. And it's a study that came out of Memorial Sloan Kettering, first author, Dr. Jason Chang, who's a molecular pathologist. And they demonstrate the presence of a major oncogenic driver in nearly all of these 200 cases. And it's the first to document more aggressive characteristics of NRG1 rearranged invasive mucinous adenocarcinomas. And there are several really important findings of this paper, including not only the further elucidation of NRG1 translocated tumors. They found a high percentage of fusions in KRAS wild-type tumors. They found that ERBB2 alterations are also common in this category of invasive mucinous lung adenocarcinomas. They also identified a novel NRG2 fusion in these tumors. So it was a really tour de force of a study. And so I'm going to highlight some of the major findings of the paper. They did find 16 fusions as part of their next generation sequencing testing, but in cases where there was no fusion detected, they found additional fusions by RNA sequencing. And this was particularly so in the cohort of NRG1 fusions, which were only detected by RNA sequencing. And again, this is really just due to limitations of assay and really the need to supplement DNA sequencing with RNA sequencing. And in their study, they were able to confirm through orthogonal methods the presence or absence of alterations. They found that NRG1 fusions were the second most common abnormality in this group of tumors. The first was KRAS mutation, and HER2 alterations were the third most common molecular abnormality. The most common gene partner for NRG1 involved CD74, and then there were also fusions between NRG1 and SLC3A2, SDC4, VAMP2, and F11. And all of these genes encode a cell surface protein leading to membranous localization of the fusion protein, as well as oncogenesis, as I've described earlier. So other notable results include the fact that by combining the DNA and RNA sequencing, they were able to pick up 96% of the alterations, including the KRAS mutations, NRG1 fusions especially, and the ERBB2 alterations. But the NRG1 fusions, again, they were identified through RNA sequencing. Overall, they found targetable alterations in about 51% of KRAS wild-type invasive mucinous adenocarcinomas. And they also had some interesting data on responses to targeted therapy as well as outcome, which I'll share in a little bit. So compared to KRAS mutant invasive mucinous adenocarcinomas, they compared and contrasted NRG1 rearranged tumors. And those tumors exhibited much more aggressive characteristics, including worse recurrence-free survival and association with more aggressive morphologic findings. There was a lower association with cigarette exposure and a much higher association with tumor size, as well as risk of metastatic disease, and particularly risk of extrathoracic metastatic disease. So here are the key histologic findings from that paper, which I'll describe, some of which are associated with aggressive pathologic findings. In box A over here, this is a case with NRG1 fusion, which shows classic mucinous morphology with tall columnar cells, basally located nuclei, and abundant of cytoplasmic mucin. The presence of aggressive histologic features, including tumor necrosis, was noted, and you can see that over here. Or desmoplastic stromal invasion was more frequently seen, again, in NRG1 fused tumors compared with tumors with KRAS mutation. And then finally, this tumor here is a tumor with NRG2 fusion. So while there are certain morphologic characteristics, I want to point out that you just cannot use morphologic findings as a reason to do testing and to look for NRG1 fusions. So I think you all would agree by now that identification of NRG1 fusion is clinically relevant. And this fusion is actually seen in a host of solid tumors. You can see here from lung cancer to pancreatic cancer to other solid tumors. And the incidence is really low. I mean, 0.3% in lung cancer, 0.5% in certain pancreatic cancer cohorts, and then less than 1% in other tumors. So the identification of NRG1, given that it's so rare, it's a bit tricky. But there are certain tumor contexts where there is enrichment of these fusions. And that's, as I've mentioned, and based on the study, in invasive mucinous lung adenocarcinomas, as well as KRAS wild type pancreatic cancers, where you can see in a quarter or about 6% of cases. So why is it important to identify patients with NRG1 fusion? For several reasons, and as I mentioned, prognosis is an important part of the clinical utility of molecular biomarker findings. And you can see here that NRG1 positive tumors are associated with poor outcomes. In the study by Dr. Chang, again, they compared NRG1 to KRAS mutated tumors, and they were able to demonstrate that patients with NRG1 fusions actually had a significantly worse overall survival as well as recurrence-free survival. And that's pretty significant. I want to just pause there, and I want you guys to just think about that for a second. So you all know that KRAS mutated lung cancers typically have an aggressive clinical course. But now you've got this subset of lung cancer that has actually a much more aggressive clinical course than lung cancer with a KRAS mutation. So I mean that's pretty meaningful to me. And so if I'll ask you a question, if you were a patient with lung cancer, wouldn't you like to know about the presence of NRG1 fusion? And wouldn't you want to know about the presence of that fusion even if you had early stage disease? So while you think about that, let's talk about how these tumors respond to existing standard of care therapies. And as I mentioned before, they do not have a good response to any of the standard therapies, and they are associated with much lower progression-free survival and much lower response rates, whether that therapy is platinum doublet-based chemotherapy, taxane-based chemotherapy, single agent or combination immunotherapy, or targeted therapy. I mean, you do have a 25% response rate to targeted therapy. That doesn't mean anything because you have a progression-free survival of 2.8 months with targeted therapies that are not directed to the NRG1 fusion. And your median progression-free survival is actually best with platinum doublet-based chemotherapy. And that's not really a great statistic as well. So basically, patients with NRG1 fusion, they're going to blow through all of their standard therapy options, and they are at a very high risk of developing metastatic disease and stage 4 cancers if they haven't developed it already. And so that is why it is critically important to identify NRG1 fusions in these patients through comprehensive profiling, both at the DNA as well as RNA levels, to provide patients with therapeutic opportunities beyond standard of care treatments. This is a very recent study. It was published in November of last year, so it's just a few months old, and highlights the absolute critical need for simultaneous or concurrent or sequenced RNA NGS with DNA NGS to maximize fusion detection. And this is a study from a well-known commercial laboratory, and a study that involved around 5,500 patients in their study. So let's take a further look into their study. And they essentially demonstrated that the addition of RNA NGS really allows for more patients to be identified. And so what they did was they performed tissue-based DNA sequencing, and this was performed via the Tempus XT assay version 4. And that assesses variants in 648 genes with 500x coverage. And these were tumors that were reviewed by pathologists with at least 20% tumor purity. And all samples had successful tissue-based whole transcriptome RNA sequencing, which was performed via the Tempus XR assay, with all assessed samples passing quality control metrics for both RNA NGS as well as DNA NGS. And you can see here that they looked at actionable structural variants, which is abbreviated as ASV. And those actionable structural variants included alterations like ALK fusion, RET fusion, ROS1, NTRK, and MET exon 14 skipping lesion. And these are all actionable today because there are FDA-approved therapies for these molecular abnormalities. So with RNA NGS, they were able to identify actionable alterations in 13 0.2% of those patients. And the addition identified 15.3% more patients with these actionable structural variants compared to DNA next generation sequencing alone. And so they also looked at emerging structural variants, which is abbreviated ESV over here. And that includes BRAF fusions, it included NRG1 fusions, EGFR fusions, and then FGFR fusions as well. And what was really interesting is that the addition of RNA sequencing actually doubled the ability to detect these emerging structural variants. And again, and you can see that NRG1 was one of those emerging structural variants at that time, but subsequently, as you know, there's been an FDA approval for therapies for patients with advanced pancreatic and lung cancer tumors with NRG1 fusion. So it's also important to know that NRG1 fusions and the detection of those NRG1 fusions is challenging. And it's challenging to detect that without RNA-based testing. And so this was a study that led, I believe this was the one that led to, was part of the clinical trial that led to FDA approval. And they showed in this study, it was the NRG1 global study, that of all of the NRG1 fusions, the best way to detect them was through amplicon-based RNA sequencing using anchored multiplex PCR. We'll get into some of the methodologies in the next couple of slides. The second most common way was through reverse transcription PCR, followed by gene expression analysis. So again, important to be able to detect these alterations through RNA sequencing. One of the most important reasons is because of the diversity of gene fusion partners and breakpoints in the large intronic region of NRG1. This is a Circos plot of the various NRG1 fusions and their upstream partners. The intensity of the bars in the inner circle, that represents the frequency of each fusion event, with the darker bars representing more common fusions, and the lighter bars representing less common fusions. So again, hopefully you can appreciate the diversity of the different NRG1 aberrations that are important to be able to detect. So I talked about NRG1 fusions, and there are a number of ways to detect these NRG1 fusions. One of the ways is through a hybrid capture NGS approach, which would be gene-specific enrichment by a hybridization step with a biotinylated DNA or RNA probe specific to the region of interest. And again, with all of these techniques, there are advantages and there are disadvantages of each of these different techniques. And it's really important to know that when either selecting an assay to bring into your laboratory or sending out for a sample that uses one of these technologies, it's really important to know the limitations as well as the advantages of each assay. The advantages of hybrid capture include the ability to characterize both the known and unknown fusions. It can be scalable. It's good for DNA and RNA gene fusion analysis. And at a DNA level, you don't necessarily require RNA purification, and so you can have simultaneous analysis of different gene variants. You do need higher RNA input than amplicon-based methods, and you can encounter difficulty with fusion variants involving large DNA intronic regions with repetitive sequences. The other common way to assess for NRG1 fusion is through amplicon-based methodologies, which can broadly be grouped into your classical multiplex PCR as well as anchored multiplex PCR. The classical amplicon-based approach involves target enrichment by multiplex PCR using fusion variant-specific primers. And so you need to know your partner that needs to be amplified. So that's one of the disadvantages. In contrast with anchored multiplex PCR, only one fusion partner needs to be targeted with a primer. And what happens in this technique is you have an adapter which is ligated to cDNA fragments, and there's a primer to that adapter, and enrichment is based on the amplification between the gene-specific primer and a primer to the adapter. So you actually don't need to know the fusion partner. So the advantages of these PCR-based approaches, which can be, again, very useful, are that they require low RNA input. They are particularly effective with small and mid-size panels. You have analysis of both known and unknown fusion variants of target genes, especially, and that's specifically referring to anchored multiplex PCR. And the 5' and 3' imbalance evaluation can increase test diagnostic accuracy. There are limitations. This is not appropriate for gene fusion detection at a DNA level. The primer design can be complex. And with certain techniques, as I mentioned, the classical multiplex PCR, you'll only identify the fusions that you're actually designing your assay for, right? And then you can have PCR bias like allelic dropout, which can impact the analysis result. And finally, another technique that's being used in laboratories is whole transcriptome sequencing. I won't go into details about the technical steps of the assay. You can actually read that over here. But again, just like the other techniques that I talked about, there are advantages and disadvantages to whole transcriptome sequencing in the sense that you have the ability to now capture all potential fusion partners, which can be helpful actually for diagnostic purposes. And if you've got certain tumors and you are trying to go fishing and actually and find a translocation that would help you diagnostically and which would also guide you to make therapeutic decisions, it's a really good technique. You have detection of expressed missed gene fusion, so you can also have gene expression that you can pick up. And you have the ability to reduce false positives caused by unexpressed rearrangements using DNA-based fusion detection. There are disadvantages like other techniques. And depending on how you fragment the RNA, there could be a wide number of biases that you can see, from fragmentation bias, length bias, transcriptome composition bias. The library preparation favors the internal transcript body, and short 5' and 3' end fragments can also get lost during the technical steps that I've outlined to the right. So again, it's really important to understand the advantages and disadvantages of each technique. But bottom line is that in a head-to-head comparison, RNA-based NGS is more sensitive than DNA-based to detect pathogenic gene fusions. RNA-based NGS can detect gene expression and structural variants, as I've shown you through numerous examples. RNA-based NGS includes both DNA and RNA sequencing, usually. RNA-based NGS reduces the technical challenges that can occur when sequencing long introns, and RNA-based NGS can improve the detection rate of DNA-based NGS alone, and provide more sensitive detection results, as you've seen in a couple of studies that I've already reviewed. So the bottom line is that NRG1 fusions are more likely to be missed unless testing with RNA-based NGS is performed during some point in the comprehensive genomic profiling evaluation process. So again, finally, just again, the advantages of RNA-based sequencing to really hit home the major points. You're overcoming difficulties caused by large introns. You're facilitating realignment and intron repeats. The sensitivity is usually retained with low tumor sample if it's highly if the fusion is highly expressed. And you're able to capture a broad range of complex genomic events through RNA sequencing. This is a summary of some of the available commercial assays that are out there. The ones in blue towards the bottom are assays that have a limited ability to identify a broad range of gene fusions. And then the ones towards the top in gray are companies that offer NRG1 fusion through RNA or DNA-based strategy in their test portfolio. And it's important to note that NRG1 might not be included at all, and really not all laboratories offer combined DNA and RNA NGS. Not all laboratories are running DNA and RNA NGS at the same time. And it's also important to know the limitations of each of the assays, whether you're a pathologist, whether you're an oncologist, or whether you're just simply a member of the local cancer care team. And so what I've listed here is it's a smattering of the commercially available assays, and it's by no means comprehensive. But again, the main point here is that you have to know your assay. Whether that's the assay that you're running internally, you'd have to know the advantages and disadvantages and the limitations of the assay, or whether it's an assay that's being sent out to a reference laboratory. And sometimes, as a pathologist, that's important to know, not only just for your own edification and for patient care, but as pathologists, you are oftentimes going to be front and center and engaging with your local oncologist and cancer care team. And you may be asked questions about your existing assay. You may be asked questions about an assay that was performed at a reference laboratory. And so that's really, the latter is I think, a situation where, it's really important for molecular pathologists and pathologists to serve as consultants, not only in test optimization, but also, what do these results actually mean? So we're nearing the end of the talk here, and we talked about a lot today, and I'd like to just take a couple of moments to summarize our conversation. We talked about precision oncology and how critically important it is for molecular profiling to be performed on patients that will allow not only the best treatments for the patient, but as I've mentioned earlier, there's diagnostic and prognostic information that's rendered from biomarker testing results. We talked about NRG1 fusion and how it's an important pathogenic gene fusion, and it occurs across a diversity of tumor types. And importantly, it's reported to be associated with poor outcomes. And I hope you'll take away the example of KRAS mutated lung cancers and actually patients with NRG1 fusions having a much more aggressive clinical course. And we talked about the details of NRG1 translocated tumors and how they have aggressive histologic features associated with increased tumor growth, invasive disease, disease recurrence, resistance to therapy, metastatic disease, and worse prognosis. And I hope you'll remember the slide which showed that these patients just absolutely do not respond to standard therapy, whether it's platinum-based therapy, whether it's non-NRG1 targeted therapy, whether it's immunotherapy used as monotherapy or in combination with other therapies. And then NRG1 fusion testing is extremely important, and I've shown you data that shows the limitations of DNA-based testing and how the addition of RNA-based NGS actually maximizes the ability to identify these really, really important fusion events. And so that's why it's recommended in order to detect an NRG1 fusion, RNA sequencing needs to be integrated into testing protocols to identify these patients because of the diversity of gene fusion partners and breakpoints and its large intronic region. And again, can't stress enough the importance of RNA-based NGS. Now, you can perform RNA-based NGS concurrently to DNA-based NGS. You can sequence it. I think it's perfectly appropriate to do DNA sequencing. And if you have an EGFR exon 19 deletion, then there's really no reason to do RNA sequencing. So that could certainly be a strategy. But it's just important to have a strategy in place, and that strategy needs to be optimized with the fact that you've got limited tissue samples, and as pathologists, we have to be good stewards of the tissue to not only maximize the ability to do the testing, but maximize the ability to detect all of the actionable targetable alterations relative to DNA NGS testing alone. And so, I'll leave you guys with a thought before we open it up for questions. I don't know if you've seen this movie. It's called Minority Report, and it's with Tom Cruise, and it's a movie back, many years ago, which maybe will tell you how old I am, but that's probably not a good thing. But anyhow, it was a very interesting movie where Tom Cruise works with this team, and they are able to see crimes before the crime actually happens. And because of their ability to see those crimes, they're able to intervene and make arrests to individuals before the crime is actually committed. It was a very, very interesting premise. And so, I think of that as an analogy for these patients with NRG1 translocated tumors, especially in lung cancer. Wouldn't you want to know, even if you had early stage disease, that you have a molecular abnormality, whether it's NRG1 fusion, whether it's a EGFR mutation? Wouldn't you want to know whether or not your tumor has an aggressive clinical course, and whether or not you are at a very high risk of developing metastatic disease? And so I would encourage all of you to think about that in light of the fact of where our field is going, and the fact that we're not testing enough patients who have advanced lung cancers. And actually today you can make a very strong argument that this testing needs to happen for all newly diagnosed lung cancer patients. So with that in mind, I will leave you with that notion. And I wanted to thank the Diaceutics team for helping to put together this very educational seminar. And I also wanted to thank the CAP Today team, Bob and the rest of the team. You guys are awesome and amazing. And thank you so much for having me on today.
Dr. Chandra, thank you so much. You've given us a great overview of the NRG1 fusions, their prevalence, their detection, many of the techniques, et cetera, that we have. We'll go through as many questions as we possibly can, including perhaps something that we need to mention vis-a-vis one of the laboratories, which I'll direct you to, Dr. Chandra, if you look in your chat that I'm sharing with you. Our first question, though, today is there a relationship between NRG1 and MET, mesenchymal epithelial transition factor, in non-small cell lung cancer? And if so, is that make a difference or an influence in selected targeted therapy?
It's a great question, and I don't know the answer whether there is a direct link between NRG1 fusions and MET alterations. As you know, MET alterations can come in many different sizes and flavors. You've got MET amplification, gene amplification. You have mutations in the DNA segment of MET that can lead to aberrant splicing of exon 14, and that leads to MET exon 14 skipping mutation. And then you can also have MET protein overexpression by IHC. And there is not a very strict correlation between when you see amplification, MET exon 14 mutation, and protein expression. There is some association, but it's not a really tight association. In general, when you have activation of the MET pathway, those patients do have an aggressive clinical course. And so, we have some data internally here at Path Group where we saw activation of the MET pathway in newly diagnosed lung cancers, treatment naive. So it does occur at the point of diagnosis, and MET aberrations also occur at the point of acquired resistance. So I wouldn't be surprised if there was an association between MET and NRG1, given that both of them, but NRG1 fusions especially, these are tumors that just have a highly aggressive clinical course. So I'm sorry I didn't answer your question, but I think it's worth a publication if there hasn't been a publication already on that specific topic.
Very good, thank you. One member of our audience, Dr. Chandra, notes that Foundation One does indeed offer NRG1 in their RNA and DNA combination panel. I just thought I'd mention that to you in case you care to comment.
Yeah, well, thank you. And that's great. There are several commercial organizations that are out there that are heavily promoting their molecular profiling assay. And whether it's Foundation or Caris or Tempus or any of the other laboratories that I mentioned earlier in the talk, it's just important to know whether the ability to detect an NRG1 fusion is part of the diagnostic strategy, and at what point is it part of the diagnostic strategy? Is it being evaluated early on, or is it being reflexed?
Yes, thank you. I wanted to get into that a little bit. I was very intrigued with your demonstration of how the enrichment through a more precise diagnosis, as in the lung cancer example where the invasive mucinous lung adenocarcinoma has a much, much greater frequency for the NRG fusion. So that leads me to the question. I think it's pretty clear, but let's make sure that we get it down on the record that if we're really pursuing the detection of NRG1 fusions, we need to use certainly RNA-based testing, correct?
That's correct. You can detect NRG1 fusions through DNA-based testing, but you're not going to be able to detect all of them, as I've shown through some of the studies that in today's talk. There are other comprehensive papers and review papers on NRG1, and the theme that you will hear again and again is at some point with appropriate, especially in patients that are driver negative in lung cancer and KRAS mutation negative in pancreatic tumors. Those are patients who will need to be offered RNA sequencing.
Thank you. Thank you very much. As expected, we have a very good question, and this is regarding as follows. Should NRG1 fusion be a target for companies in the digital pathology world to build a predictive biomarker panel around? That's a very timely question, I think.
Yeah, that's an excellent question. And so let me put some context behind that question.
Please.
There are digital pathology-driven AI tools that are already becoming commercially available, although this is not recommended in guidelines, and again, it's kind of more in a research setting. But these tools, believe it or not, based on the H&E image and through computational pathology algorithms, they can identify the absence or presence of certain molecular abnormalities, ranging from homologous recombination repair deficiency to the presence or absence of certain molecular events like TP53, EGFR, KRAS mutations. So I do think that, potentially in the future, if you're able to, at the point of diagnosis, have an AI algorithm that identifies patients who have one of these molecular abnormalities, those are patients that you would want to confirm with downstream molecular testing to, confirm whether, which of these molecular abnormalities are present. Conversely, if you have an algorithm that with a high degree of likelihood tells you that there are no molecular abnormalities worth targeting, then why would you bother sequencing and spending thousands of dollars on those patients? And then finally, if you know that there's an EGFR mutation present, why would you want to do a 500 gene panel and not just EGFR mutation alone? So again, this is a field that is rapidly moving, and we're keeping our eye on it. And I encourage you all to read up about it, because it's going to revolutionize the way that we practice pathology. And for those of you that are molecular pathologists, you're going to have to reimagine the delivery of molecular pathology in the context and in the world of digital pathology and AI algorithms.
Very good. Thank you. We've had several questions around targeted therapies, and I'll let you say as little or as much as you wish to, but at least could you answer the question, are there targeted therapeutic approaches to the NRG1 fusions being worked upon or in consideration?
Yes, absolutely. I alluded to it in the talk, but there has been an FDA approval for an NRG1 directed targeted therapy, and that approval is in the context of lung cancer and pancreatic cancer.
Very good. And you can follow up and get more information offline from Dr. Chandra or Diaceutics, or even ourselves if you wish. Thank you very much. One final question. I think we're just about at our time. Again, another good one. We've got an expert group in the audience, as well as having a premier expert presenting today. So I'll ask you the final question, Dr. Chandra. Is there diversity in the type of NRG1 fusions that are observed in patients? To put it another way, our questioner says, are there common partner genes involving specific regions?
Yeah, there are common partner genes, which I covered earlier in the talk, but there's enough of a diversity of those gene fusions that you really need to take a comprehensive molecular profiling strategy to be able to capture as many of those gene fusions as possible.
Very good. Thank you so much for that. And I want to thank you once again for having given us such a superb presentation. We will post this, and if we need to alter a table to correct it, we will do so before we post the slides and this wonderful audio and lecture that we've heard today. And so I want to just simply begin to wrap up. I want to thank Dr. Pranil Chandra of Path Group. He's given us an extraordinarily rich discussion today of the NRG1 fusions. We look forward to working with him again. It's always a pleasure. I do want to thank Diaceutics for their sponsorship through an educational grant. Diaceutics is a company I think you should all be knowledgeable about it, know about. They're deeply interested in the work that labs and pathologists are doing in this field. And finally, I want to thank all of you. I know that we're very, very busy in laboratories today. I also know we have manpower issues almost everywhere. And so it's very gratifying for us, and it's a pleasure to recognize you for taking time out of your busy day to join us for these webinars. And I'm very interested in your thoughts and afterthoughts of them as well. So with that, I'll just go ahead and wrap up quickly now. Thanks to Dr. Chandra. Thanks to Diaceutics. Thanks to all of you. And now I will bring today's webinar to a close.